the abdominal exam with a focus on appendicitis. For the sake of time, I'm not going to read this whole slide, but subjective data to collect during a normal abdominal exam includes an HPI, past medical history, family history, social history, as well as a thorough review of systems.
Fine. I'm going to begin my exam by asking the patient to empty their bladder and lie supine on the table with their arms relaxed to their side. I'm going to expose the abdomen and inspect the skin, the contour, and the movement. I'm also going to have the patient raise their head off the bed to engage the abdominal muscles and inspect for any hernias, any masses, or muscle separation. The patient can relax. I'm going to move on to auscultation using the diaphragm of the stethoscope to auscultate all 4 quadrants, listening for 5 to 35 clicks or gurgles per minute. I'm also going to auscultate over the liver as well as the spleen for any friction rubs, which would be an abnormal finding. I'm going to use the bell of my stethoscope to auscultate the aorta, the renal arteries, the iliac arteries, and the femoral arteries for any bruits, which would indicate turbulent blood flow and be an abnormal finding. Next, we'll move on to percussion, which can help identify any masses, fluid, and organs. Percussing all 4 quadrants should be predominantly tympanic. To assess the liver span, I'm going to start at the right midclavicular line below the umbilicus, percussing upward through tympanic sounds until I hit dullness, indicating the lower edge of the border. Moving up that right midclavicular line, I'm going to percuss downward through resonant sounds of the lungs till I hit dullness, indicating that top margin of the liver. The span should be anywhere from 6 to 12 centimeters in a healthy adult. You can also percuss the spleen on the left side, percussing downward through lung resonant sounds. Dullness can be heard between the 9th and 11th rib. However, below that should be tympanic. Moving on to light palpation to assess any rigidness or tenderness. Palpating all 4 quadrants should be smooth and soft. Deep palpation can be done to assess for any masses as well as organs. So to palpate the liver, I will place my hand behind the patient between the 11th and 12th rib and press my other hand on top, pushing down as asking the patient to inhale deeply. That lower border of the liver should be non-tender, firm, and smooth. The gallbladder also lives in this area. However, in a healthy patient, it should not be palpable. The spleen on the left side should also not be palpable in a healthy individual. However, if you can feel it below that left costal margin, it can indicate an enlarged spleen. To palpate the kidneys, you can use the capturing method on each side. However, in a healthy individual, the kidneys may or may not be palpable. To palpate the aorta, you can start a little left of the midline, palpating and assessing for any pulsation. Any strong lateral pulsation can indicate an aneurysm, which would be an abnormal finding. The bladder in a healthy individual that has just emptied their bladder should not be palpable. Lastly, what I'm going to have my patient do is sit up, and I'm going to assess for any kidney tenderness. I'm going to place my hand on the costovertebral angle and percuss. This should not be painful or tender for the patient. Fine.
Subjective data for appendicitis. In terms of onset, the patient usually presents to the provider within 48 hours of symptom onset. When asked where the pain is located, the pain initially is present in the periumbilical and epigastric area, then later becomes localized to the right lower quadrant. In terms of duration, the initial diffuse periumbilical epigastric pain is rapid in onset and localizes to the right lower quadrant within 12 to 24 hours typically. When asked to describe the pain, patients often describe it as colicky. In terms of aggravating factors, movement as well as pressure on the abdomen can make pain worse. When asked what relieves the pain, sometimes lying still or flat can relieve pain. In terms of timing, the pain is often described as constant without a specific pattern. And then in terms of severity, the pain is often described as worsening over time. Positive findings on a review of systems include low-grade fever, nausea, vomiting, anorexia, and loss of appetite, as well as constipation or diarrhea.
So a patient with appendicitis will present with either epigastric periumbilical pain or more localized right lower quadrant pain. Taking note of this, these areas should be examined last during the abdominal exam. Upon initial palpation and percussion of the area of pain, most likely the right lower quadrant, there will be guarding, rigidity, and tenderness. There might also be skin sensitivity. It is also worth taking note of the patient's facial expression, given grimacing and outward signs of discomfort may be present in their expression. Beyond the regular components of the abdominal exam, there are other tests you can do to point towards a diagnosis of appendicitis. Positive Rosting sign is seen when palpation of the left lower quadrant initiates pain in the right lower quadrant. There is also an ileoceous muscle test, which can be done by placing your hand on the patient's right upper lower thigh, asking them to lift their leg off the bed against your pressure of the hand. If there is pain during this test, it is a positive psoas sign, indicative of iliopsoas muscle irritation due to an inflamed appendix. The next test you can do is called an obturator muscle test, asking the patient to flex their leg upward at a 90-degree angle, rotating that leg medially as well as laterally. If there is pain upon this test, it is considered a positive obturator test, indicative of obturator muscle irritation due to, again, an inflamed appendix. The McBurney's point can be found by drawing a diagonal line from the umbilicus down to the right hip bone. That midpoint is the McBurney's point. Palpation causing sharp pain as well as rebound tenderness in this area is indicative of appendicitis with associated peritoneal inflammation. A positive Aaron sign occurs when palpation of the McBurney's point causes stomach pain or heart pain in the patient. Lastly, one test you can do is asking the patient to stand. You'll have them raise their heels off the floor, going onto their toes, and then having them drop their heels back onto the floor. Any pain with this test is considered a positive Markle's test, or otherwise known as a heel jar, and is also indicative of appendicitis with peritoneal inflammation.
Risk factors and differential diagnoses. Differential diagnoses to keep in mind are ectopic pregnancy and pelvic inflammatory disease in females, diverticulitis, gastroenteritis, inflammatory bowel diseases, and colon cancer. This is not an exhaustive list. Risk factors include appendicitis being more common in men, especially men with a family history of appendicitis. And then the peak incidence tends to be between ages 10 to 19 years old. However, anyone of any age can develop appendicitis. And here are my references.